Right. As you know, we are doing lectures series on the cardiology, basic and clinical. Today we are starting a special area, that is right atrium and its walls, right, especially from inside, the interior of the right atrium. The classical way to teach was that we used to teach that right atrium has 6 walls, but actually it does not have 6 walls or 6 walls. It doesn't have anything like that. It is basically elongated, relatively irregular pouch type area or ellipsoidal area, right? But for teaching purposes, in traditional anatomy, we used to teach it as it has 6 walls, and when we talk about 6 walls, we mean that, let's suppose this is its posterior wall, right, elongated, and then there is, let's suppose here is medial wall, right, medial, floor and roof, and then you can think of lateral wall on this side. This is medial wall, and now you have 6 walls. For example, one, what is this? Medial wall. Then there is posterior wall, then there is lateral wall, and then there is this wall which is going in this direction. This one is, I have cut it down, but that is basically interior wall, right? And then there is, fourth is interior, then roof and floor. This was traditional way to explain the right atrium wall by wall. But in modern cardiology, actually right atrium is divided into 4 regions, not 6 walls, 4 regions, and we say there is septal region, behind and above there is, for example, there is one septal region. In modern cardiology, we say there is septal region, then there is sinus, yes, venerum, and then there is trabecular region, and then there is tricuspid vestibular region, right? Now what I will be doing, I will be teaching in an integrated fashion, that for example, today our day is to teach medial wall, right? But whatever region is relevant with that, for example, septal region is relevant with the medial wall, we will discuss about that. So as we will keep on moving, discussing the walls, we will also keep on discussing the modern morphological region also. But the most important thing which I will be doing is that with every wall, I will be strongly integrating the clinical correlations, because there is no fun in studying any atrium or ventricle if you don't know its clinical correlations, right? So the real lecture is that it is from basics to the bedside with crystal clear concepts. So let's start with the medial wall, right? Now when we talk about the medial wall, in traditional ways, when we used to teach medial wall, we could draw that there is heart like this, and then here is septal area. Yes, this was our classical way to explain, which is of course now considered wrong. But first I will tell you what was traditional or classical and why it is wrong, and why modern concepts related with the medial wall are important. And if you don't respect the modern concepts, how you can kill the patient if you are interventionist or you are in cardiology who is playing with the catheters. Anyway, so previously or traditionally we used to say that here is right atrium and here is left atrium, and this plain wall is basically septum, interatrial septum. This concept is now not considered right. Why? Let me explain. The modern concept is that when you are standing, let's suppose you happen to stand here and you're looking at medial side, for example, you minimize yourself and somehow you enter into right atrium, and here is the medial wall. You're looking at the medial wall. Now all this wall which is looking medially, superior part, middle part, lower part, all of it is apparent medial wall, right? But all of it is, which is apparently medial wall, in traditional science, it is looking in this diagram as if the whole wall is inter-atrial. This is not true. Why it is not true? Let me draw a diagram to highlighting the modern concept, right? Modern concept is that basically between the right atrium and the left atrium, the true wall is Fossa Ovalis and little surrounding area. For practical purposes, you should remember the real interatrial wall. The wall which is between the atria is only Fossa Ovalis. For example, if Fossa Ovalis is, I will explain what is Fossa Ovalis. Let's suppose Fossa Ovalis is only this region, right? Then only this region is interatrial wall or septal wall. But why this is not presently considered interatrial septal wall? Why? Let me redraw it. Actually, classically, first I should draw, suppose this is Fossa Ovalis, right? Actually, what really happens that if this is right atrium, it will have its wall coming down, and there is left atrium, it is also having a wall which is coming down, and you look at it now, the point which I am trying to highlight, this is central fibrous body. I will discuss that later. You can see, if you're looking from here, you are looking at Fossa Ovalis. But Fossa Ovalis, it's a very thin membrane, especially floor of the Fossa Ovalis is a very thin membrane. So, okay, let me make it blue. Now this is a very thin membrane. The beauty of this thin membrane is, if you have normally developed interatrial wall, now the beauty of this is that if you puncture at any point here, you will right away enter into left atrium. There will be no intervening tissue other than the original tissue of floor of Fossa Ovalis, right? But if you, for example, try to enter from superior or posterior area of the medial wall, for example here, right, you cannot directly enter. Why? The reason being that there are infolding of superior and posterior walls of atria, right? And here they have extra cardiac tissue. For example, what is this? Pericardium. So pericardial layer is even entering here. Look at it, right? There is visceral pericardium and there is parietal pericardium. Both of them are going here. And even there is, let's suppose here, there is adipose tissue also, which is extra cardiac adipose tissues. It means even though this part of the wall, if you are looking from here, it looks as if it is interatrial wall, but actually this is a folding, infolded, both atrial walls coming down, meeting the fossa ovalis. And if you puncture from here, because this is a very important concept in modern cardiology, that there are many procedures we do via the needles and catheters, and for many procedures which we are going to do on the left side of the atrium, actually we pass the catheter through the femoral vein and eventually it goes to the inferior vena cava and then it reaches right atrium. From here we make a transseptal puncture and we come to the left side, and then the operator can manage different pathological situations in the left atrium. That I will discuss later. But what I am trying to say, that if you don't puncture through the floor of fossa ovalis and you puncture from some superior area or from posterior area or from very interior area, actually you puncture the right atrium and you may end up into outside of the right atrium, into extra cardiac tissue or some other neighboring tissue, and it can produce lot of dangerous complications, right? And of course, if someone is very much, I can say, stubborn, he say, no, I want to reach to the left atrium from here, he can. But unfortunately, first he will puncture the right atrial wall, then he will pass through the extra cardiac tissue, right? Extra cardiac tissue including the pericardium and pericardial cavity and even some extra cardiac adipose tissue, right? And then he will again puncture the wall of, what is this? Left atrium, and then he will reach the left atrial wall. So it means if you don't really go through fossa ovalis floor, right, then you still can try to reach the left atrial cavity, but in this procedure you will come across extra cardiac tissue and you might leave the right atrial cavity. So that is not the right thing to do. That can damage. For example, if you produce a puncture here and bleeding occurs into pericardial sac, what will happen? If lot of bleeding, blood moves into pericardial sac and blood start accumulating into pericardial sac, right? What will happen? Pericardial effusion will be initially of the blood. But the real problem is, as this blood is very rapidly leaking out into pericardial cavity, it will accumulate into pericardial cavity, and as pericardial cavity pericardial cannot stretch that rapidly and accommodate so much blood, so pressure in the pericardium will go very high, and that pericardial cavity which is full of the blood, that will compress the cardiac chambers. That will produce a clinical situation called cardiac tamponade, which we will discuss later, right? Now, the real thing which I wanted to tell you, that all the medial wall is not truly inter-atrial wall or partition, right? Now, if I open this wall like this, for example, if this is the medial wall, right, I show you like this. Actually, medial wall is little directed forward and interior and moving towards the medial side, facing towards the medial side in the right atrium. Now, here you will find there is fossa ovalis. Let me draw only medial wall here and fossa ovalis. Let's suppose that this is medial wall, and in this here are fossa ovalis. Yeah, it is smiling. So this Concept of this should be clear for any person who is trying to learn cardiology in a good way. Fossa ovalis, this is the floor. Now area around fossa ovalis is raised. We say there is a rim or elevated area around the fossa ovalis. Now this elevated area, right, what is this? This is infolding of, this infolding, atrial walls. So if you want to puncture, you have to go through this area, because if you puncture here somewhere, right, you will just go through the membrane of the fossa ovalis. This membrane is primarily derived from, septum primum. We will not discuss embryology in detail because this is not a lecture on embryology, but we will discuss the relevant embryology, right? Now, relevant embryology, as I will discuss later, for a while, you just trust me that this wall of the fossa ovalis, which is the floor of the fossa ovalis, or if you look at directly on face to face, this fossa ovalis, this membrane is derived from septum primum. Septum primum. Septum primum. Now, actually the main tissue which is truly between the blood of the right atrium and blood of the left atrium is septum primum, right? Floor of the fossa ovalis, floor of the fossa ovalis, right? So whenever you are going to make transseptal puncture, you must go through floor of fossa ovalis or this fetal remaining part of septum primum. You should not go from other areas which are, okay, these are dangerous areas. These are dangerous areas. You can even anteriorly or superiorly and especially posteriorly. What are these areas? These are infoldings of atrial walls. What else they have here? They are having extra cardiac tissue. It is worth repeating, extra cardiac tissue in which there can be even pericardial membranes, pericardial cavity, potential cavity, and even adipose tissue, right? So this is an extremely important thing about medial wall. So if I say, I will make it a simple medial wall, that let's suppose we were talking about 6 walls, this is posterior wall, and let's suppose here I make the medial wall and here I open the lateral wall, right? Now this is the medial wall. Let's suppose here is your fossa ovalis, right? Then what will be this? There is a rim which is more pronounced. This is also called limbus of fossa ovalis, a thickened area around the fossa ovalis floor. And this thickened area, or which is called limbus, it's worth repeating, it is basically not septum secundum. Oh, now you are in trouble. Because most of your book, which are classical text or the traditional text or whatever you were taught previously, actually it was thought that if this is derived from septum primum, then this area is derived from septum secundum. This is also absolutely Wrong, right? This is not mainly derived from septum secundum, it is mainly derived from inter-atrial infolding. It is mainly derived from inter-atrial infolding, right? So we have made two concepts clear. Number one, the whole medial wall is apparently a big medial wall. All of it is not truly inter-atrial septum. True interatrial septum is the floor of the foramen ovale or ovalus, and this floor is basically, this is little depressed, and classically speaking it is not depressed. Actually around it, the rim of this interatrial muscular folding, that is little elevated, and this looks as if it is depressed, right? So this smooth floor of fossa ovalis, which is basically footprint of septum, fetal septum primum. This is the main area where blood from the right atrium is on one side and blood from the left atrium is on the other side, and if you puncture here, you don't pass through any extra cardiac tissue. This is the most appropriate and best shortcut and to the point puncture point for transseptal puncture, right? Yes, you have a question.
Sir, you have said a word, foramen ovale. Is fossa ovalis and foramen ovale the same thing?
No, fossa ovalis is adult. Foramen ovale is in prenatal life. I will explain later what is foramen ovale when I discuss about from where this comes. If I have said foramen ovale, I shouldn't have said it. Basically, I meant fossa ovalis. Because right now we are talking about the adult right atrium medial wall, and this is fossa ovalis, right? In fetal life, there was an opening here, and that was called foramen ovalis. We will discuss that within few minutes. First, I want to hammer in your mind, in your all layers of cerebral cortex, that the medial wall, all of it, apparently all of the medial wall, which looks quite big, is not really the true neighbor of the right atrial blood and the left atrial blood, and because in modern area, all over the world, millions of cardiology procedures are being done, it's in millions globally, in which transseptal punctures are done. So we must correct our concept that this is the place to puncture. If you puncture from other places, you will be in trouble. Why you will be in trouble? Let me tell you. One thing I told you, that if you puncture from this area, right, you can go to pericardium, and you can lead to cardiac hemocardium or cardiac tamponade, right? Second complication, okay, what is cardiac tamponade? Then I will tell you the second complication, which is even more dangerous. You know what is that? You come to you puncture from here to not only moving to the left atrium, but you are moving interiorly. If your puncture point is too much interior, you know what is a dangerous structure lying here? Your biggest artery, the root of aorta. Root of aorta. So what happens? Let's suppose here I am showing the aorta. Here is atria on the back. Now, if I remove the aorta, you can say aorta is just at this point. From left ventricle, it is going upward, right? So it is moving in front of the, yes, septal area or medial wall. If you, from left ventricle, aorta will exit upward. Now, what will happen? From here, if you move the needle interiorly, you can puncture aorta. That can be a big tragedy. So, again, It is not only about, sometimes even you are still puncturing, what is this?
The true
Fossa floor. But if you are puncturing too interiorly, you can hurt the
root of aorta.
root of aorta, right? It means it is not only important that your puncture point should be within, what is this? Septum, right? It is also very important that what is the direction and trajectory of the needle, that is called the vector, right? So we have to be very careful that where we are making puncture and what is the direction of the needle also. If number one, puncture should be made, transseptal puncture should be through the septum. Which septal? Septum, not anywhere in the medial wall. You have to locate where is the floor of the fossa ovalis. Then there you have to do puncture. And what should be the direction? Direction should be very carefully chosen according to which procedure you are going to do. We will discuss even that later. Now it is clear that whole medial wall is not inter-atrial septum. Any question up to this? No. 2 points we have made it clear, right? I will repeat it. 1 point, it should be clear in your both hemispheres that the wall between the two atria, true wall is only or mainly the floor of fossa ovalis, and other area around it, especially interior, superior and posterior, that is interatrial folding with some extra cardiac tissue, and that can lead to real and serious complications if you puncture through that, right? Number one. Number two, I think made it clear that this especially upper portion and posterior portion, which is little bit elevated towards the atrium, right? It looks like a rim around the fossa ovalis, right? This rim is not derived mainly from septum secundum. It is mainly derived from interatrial infolding walls, right? Atrial walls which are coming down and infolding with each other. Clear? Now, related with the medial wall, there are two clinical concepts which confuse the student too much. Related with the medial wall, there are two more clinical concepts. Number one, what is patent? Yes, fossa ovalis. What is patent fossa ovalis? Number two, is it atrial septal defect, or if it is not atrial septal defect, atrial septal ASD, septal defect. The most common atrial septal defect is, yes, ostium secundum. Now we will discuss this. First of all, I want to tell you, patent foramen ovalis. Patent foramen ovale or ovalis is not atrial septal defect. Patent foramen ovalis is just considered a normal anatomical variance, right? It is not atrial septal defect. And how it is different from most common atrial septal defect, which is ostium secundum. To understand this thing, we must go back to the fetal life, right? from where the originally foramen ovalis came, foramen ovale or ovalis came, and why in many people it is patent and many other people it is not patent, not open. Let's go in fetal life. When we talk about fetal life, I make a very simple heart here. Superior vena cava, right atrial lateral wall, inferior vena cava, right, and then this is and here is left mitral valve, now I'm making it red to make it more clear. This is suppose left side of the heart, right, and here is the right side of the heart. Now in fetal life, what really happens that lungs are not aerated. No one is breathing in fetal life. There is no air going in and out of uterus, right? So from where the baby get oxygen? A fetus get oxygen from the placenta through the umbilical vascular system. So what really happens that in fetal life, our lungs are not functional as far as aeration is concerned, as far as breathing is concerned. Inspiration and expiration is not going on, right? So, how the blood get oxygenated? That is from the placenta, right? Now, the blood from all body of the fetus and from the placenta, they are coming through inferior vena cava to the right atrium, right? Now, in adult, story is different. I will compare this fetal with the adult. In adult, what happens that I will separate the right end. Suppose this is the right, and here is the lung, and here is the left heart. I made it little separate, and now the pathway of the blood in the adult life is, for example, in my body, what is happening, or your body, if you are adult, I hope so, that from upper part of the body, blood is coming from superior vena cava, from lower part of the body, blood is coming from inferior vena cava, right? Interatrial septum is closed, right? And blood is going from right atrium to the, through the tricuspid valve to the right ventricle. From there it is pumped into pulmonary artery, right? And pulmonary artery take the blood to the pulmonary capillaries, pulmonary micro circulation. And here is the air coming, right? Suppose here this is the air pocket. Now blood, normally in adult, blood is passing through this area, leaving the carbon dioxide here, acquiring the oxygen here, and oxygenated blood from the pulmonary veins. There are 4 pulmonary veins which drain into left atrium, and then blood goes through mitral valve into left ventricle, and then through the aortic valve the blood is pumped into systemic arterial system, and eventually it will come through the systemic circulatory system back. This is the normal, what is happening in adult. Now in fetus, what is happening? Lungs are not working. There is no fun in sending the blood, because blood is coming in the fetus, blood is coming from the body which is deoxygenated, and blood is coming from placenta which is oxygenated. Both of them get mixed and they reach right atrium. But in fetus, it should not go all of it to the left right ventricle, and it should not go through pulmonary system to the lungs, because lungs are not working. So what should we do? We should bypass the pulmonary circulation, right? So how it happens? In fetus, primarily, there is a shortcut for the blood. There is a special window between the right atrium and the left atrium, right atrium and the left atrium, and this window is called foramen ovale, right? So what really happens that inferior vena cava, it has a special valve like structure here, we call it Eustachian valve. It directs the blood to the foramen, from here to the foramen ovale, not to tricuspid area. Minimum will go to this side, and through the foramen ovale, which is open during the fetal life, blood will go directly to the left ventricle, and from there, go to the left atrium and then left ventricle, and then to the aorta, to the rest of the body. So, in fetal life, what is happening? There is something special between the right atrium and the left atrium. That whatever blood is coming to the right atrium, the blood which is returning from the placenta, that is oxygenated. We don't want to take it to the pulmonary circulation, right? Why we don't want to take the pulmonary circulation? Simply because pulmonary circulation is not having the air, not having the oxygen, right? It cannot get the exchanges because pulmonary alveoli are collapsed in fetal life. So, actually, even if blood comes here and try to go to the pulmonary artery, try to enter the pulmonary circulation, there is a trouble because lungs are collapsed, right? So, there is too much resistance for the blood to move towards the fetal pulmonary circulations. There is too much resistance to move the blood from the right heart of the side through the pulmonary arterial system to the pulmonary remaining circulation due to very high resistance during fetal life, right? So, due to that high pulmonary resistance, right, blood cannot go to the lungs, and that will keep the pressure in the right atrium high. And during fetal life, as pressure in the right atrium is high and this foramen ovale is open, so blood will keep on shunting physiologically from right atrium to the left atrium. So, this foramen is normally there in fetal life. Now, actually, this foramen, I will make it more clear here. Let's suppose these are ventricles and these are the atria, this is fetal. Now, here is foramen ovale. From here blood can go from right side to the left side. Here there is a flap, okay, I will make it a little downward, yes. This foramen ovale, a membrane like structure develop over here and that partially covers. And from here, as I mentioned, enfolding comes, right? But as long as fetal development is going on, this remains open and blood keep on moving. Is that right? But this flap is there. Flap is there. Now what happens? When baby is born with first cry or first breathing, inspiration, if baby is healthy and if lungs of the baby are mature enough, with first inspiration, lungs will inflate and alveolar system will open and air will go in. And when air will go inside the lungs with the first breathing or the first cry of the baby, then pressure in pulmonary circulation will drop. Pressure in pulmonary circulation will drop. So, now if pulmonary circulation, this is pulmonary circulation, when lungs will get well aerated, right? Resistance to flow to the lungs will become less. Then blood, rather than going through this, all of it here, some of it will keep on trickling from here to the lungs. And because lungs resistance, pulmonary vascular resistance is going down with breathing, so more and more blood will start going to the pulmonary circulation. What does it mean? That after birth, more and more blood will be arriving from pulmonary veins to left atrium. So pressure in the left atrium will start going up. Pressure in the left atrium will start going up. Then pressure when left atrium will start going up, what will happen? When from the lungs, blood is coming here after the birth, right? Pressure here will go up. Then this flap, which was like this open due to high pressure here and less pressure here, will move towards the opening and close the opening. And foramen ovale will be closed after the birth. In this way, after the birth, I can say that this was our, like this, from here it moved and eventually it closed it like that. Now, I will not teach you the whole embryology, but I just want to tell you this flap which is closing the foramen ovale, this is derived from, yes, from septum primum. It is derived from septum primum, right? Now, after once it closes, we say the foramen ovale is no more there, but there will be little depression present still. This little depression, because atrial enfolding is making a thick margin around it. This depression, right, this will be, once it is closed, then it is not called foramen ovale. After the birth, after the closure, which occurs after the birth, this is called fossa ovalis or fossa ovale or fossa ovale, whatever you love to call it. The thing is that you should understand what it is. So in adult, if you enter in my right atrium, right, and you look towards the medial side, you will find a big medial wall, which I will say you are looking at apparent medial wall, which is apparently looking as if it is the partition between the right atrium and the left atrium. In that wall, you will find a little depression. And that depression, if this is the medial wall, here is the depression, and this depression is called fossa ovalis. And this fossa ovalis was originally foramen ovalis, which is now closed by the septum primum, right? Now I want to tell you something. Many students have another confusion here. They think that in most of the people after the birth, it is really sealed. It is just like that this was fossa, right, and this was septum primum. After the birth, when left atrium got more blood, then it was closed like this. Once it is closed like this, then fibrosis will occur, right, and what will happen? The contact point between the septum primum tissue and this tissue, which is bordering the foramen ovale in fetal life, these two tissues will undergo fusion, biological fusions, fibrotic process, and we say that foramen ovale is closed. And what has happened, that if you look from the medial side, right, this was what? Septum primum, and this margin is basically basically this margin is not the, it is medial side. If you, that is the medial side you are looking, then this is the margin or limbus, and here is, what is this? Septum primum. What is this? Septum primum. This is fetal life, septum primum. In a very simple terms, it is more complex than this, what I am telling you. But for practical purpose, adult, this closes, right? And foramen ovalis convert into fossa ovalis. From medial side, if you look, there is a little depression with a elevated margins, right? And this is the place from where you can puncture and go directly to. Now, what is patent foramen ovale, PFO? Wow. Every fourth person, almost, out of all of us, every fourth person, this septum primum does not seal completely, does not stitch biologically completely. There is some opening remain there. That is not opening, that is potential opening. What I am trying to say? That if this is a window and primum is as a curtain, right? Now this curtain, let's suppose window is with elevated margins, right? Now there is curtain in between. The margins of the curtains should be stitched here. Is that right? It is true. Now this curtain is what? Curtain is basically septum primum. In about 70-75% of the people, this septum primum is fused or sealed, right, with the margins of the fossa ovalis. But in every fourth person, some area is not stitched. For example, this area is not stitched, or this area is not stitched. So in every fourth person, foramen ovale, right, this is from right side coming to the left side, right? In fetal life, blood was coming like this, but then, and for what was this? Septum primum, right? The septum primum was open. Okay. Now, okay, I can make it like this. This is the right atrium. This is the rim of the fossa ovalis, and this is, if this is open, then we call it foramen ovalis. And what is this? Septum primum. Is that right? And here is left. In fetal life, pressure here is more. Blood is not going through the pulmonary circulation, and blood through the foramen ovale or ovalis moves from the right side of the heart to the left side of the heart and goes to the systemic circulation. And primum, septum primum is not closing. Now, after the birth, pressure in the lungs become less. Blood which is coming to the right atrium through the left ventricle, it moves to the pulmonary circulation. And from pulmonary circulation, more blood is coming to the left atrium. And pressure in the left atrium goes up. When that pressure in the left side goes up, then primum is pushed, septum primum is pushed against this rim. And once it is, and remember, this rim is not made of septum secundum. This is our previous concept, which is now proven to be wrong, right? It is mostly posteriorly and superiorly, it is basically enfolded walls of the atrial muscles, right and left. Now, when primum will close after the birth. Once primum closes, right, the foramen, it becomes now fossa ovalis. Most of its margins will be fused, but in 75% it fuses completely, about 25% some area does not close. Now what happens? Nothing happens most of the time. Why? In most of our adult life, pressure on the left side of the atrium, left atrium remains more than the right atrium. So even if it is not completely sealed, but still it remains pressed against the rim of the or margins of the fossa, and there is no blood communication or shunting of blood from left to right or right to left. Is that right? Is it clear? But this every fourth person in which there is incomplete, what is there incomplete? Incomplete biological stitching or incomplete biological sealing, right? Or when due to incompletion we can say there is potential tunnel, potential communication between the right and the left. Potential means it has a potential to make a communication between the right atrium and left atrium, but this potential is not used all the time, right? So usually there is no issue, and such partially sealed septum primum, which are making the floor of fossa ovale, right? These partially sealed are called patent foramen ovale. So we can say in the world 25% of the population is having foramen ovale which is patent to some degree, or unsealed at some degree, or unfused to some degree. Here I want to stress a point. The point is, if this is the border or the rim where septum primum has to close, here is right atrium and here is left atrium. It has to fuse here. Even if it does not fuse completely, as I mentioned, that pressure on the left side is more and pressure on the right side is less. Due to this reason, what happens, it still remains closed, and most of the time there is no problem. But because there is some potential under certain circumstances, which I will tell you right now, this can be opened and blood can obliquely move from right to left. Because it has a potential, so we call it patent foramen ovalis. It is so common that now many authorities believed that it should be considered a normal anatomical variant. If every fourth person is having it, then we can consider it normal anatomical variant. But sometimes it can be source of trouble. How it can be source of trouble? You must have heard of something called deep venous thrombosis. That blood clots form in the deep veins, deep venous thrombosis. If someone is having deep venous thrombosis, normally what happens? That if that thrombus, suppose it is in deeper veins of or big veins of the leg, femoral vein, if thrombus detached from here, we say and that thrombus piece which is detached from the vein that is moving in the blood, it becomes embolus, or we say thromboembolism is going on. So normally what happens, God forbid, if someone has a significant thrombus in deep veins, anywhere in the body, very common in the pelvis and pelvic veins and lower limb veins, if some piece of thrombus detaches and start freely moving in the blood, as veins move towards the heart, towards the superior vena cava and inferior vena cava, they are progressively increasing their caliber, so this thrombus or blood clot will be taken to the right heart, right atrium. Normally, usually, if deep venous thrombosis, right, from the deep veins of the legs come to the right heart, normally it will be pushed into right ventricle, then pushed into pulmonary artery, and pulmonary artery will progressively divide into smaller vessels, then arteriole, then eventually capillaries. So according to the site, somewhere in pulmonary arterial system, that clot or thrombus will be stuck. Thromboembolism will occur in the lungs. This embolus originated from deep veins of legs or pelvis or anywhere in the venous system, right? and from there it detached and came to the right side of the heart, and normally it gets pumped to the pulmonary circulation, and in the pulmonary circulation it eventually blocks some arteriole or artery depending upon its size, right? And even it can lead to then damage to the lungs, right, or infarction of a part of the lung. This process is called pulmonary thromboembolism. But remember one thing, it can be fatal if it is too big. But anyway, if it is smaller and patient survives, because pulmonary arteries, when they enter into lungs, they progressively go into smaller arterioles and eventually into capillary microcirculation. So all deep venous thrombi, which are small, they will be filtered into pulmonary circulation, and they will not be reaching to the left side of the heart, right, and they will not be coming to the left atrium, and through the left atrium they will not be pumped into left ventricle, and through the left ventricle they will not be pumped into systemic circulation. Is that clear? Now, patient with patent foramen ovalis, sometimes they can be very unfortunate. That if they have there are two conditions which should be there. Number one, 2 or 3 conditions or 4 conditions. Number one condition, they are having deep venous thrombosis. Number 2 conditions, a part of thrombus or full thrombus is detached and it is becoming an emboli and moving towards the right heart. And when they happen to be in the right atrium, at that very moment, when that clot or that thrombus was passing, not thrombus truly now because it is mobile, embolus, it is passing through the right atrium, very unfortunately, some situation happens. I will tell you what is that some situation. Some situation happens. And pressure in the atrium becomes, right atrium becomes more than the left side. And blood pushes this unsealed part, which is present in 25% of the population, a little away. And very temporarily it is possible that there is shunting of the blood from the right atrium to the left atrium in the patient with patent foramen ovale. And when this shunting will occur, what will happen? If thrombus is here or embolus is here, that might go through that blood to left side of the heart, and then go to the left ventricle, and then go aorta, and it might go straight to the brain and produce stroke. And this stroke is called cryptogenic stroke. And this thromboembolism is called, yes, paradoxical thromboembolism. Let me define it. Wow. What is paradoxical thromboembolism? This occurs most commonly in those people which are having patent foramen ovalis, right? And this thromboembolic piece is passing through the right heart, and at that very moment, pressure in the right atrium increases and blood shunts through the unsealed part of patent foramen ovale to the left atrium, and thrombus may go. The question is that why pressure increases here for some time? Answer is, if that very moment when thrombus was transition, when thrombus was passing through this, or thromboembolic embolus was passing from here, at that very moment patient sneezes or coughs or strains or Valsalva maneuver, or he does anything which increases the venous pressure. This is really unfortunate, because many young patients, when they develop stroke in a very young age, many of them, when they are investigated well, sometimes it is found that they are having patent foramen ovalis. So what did they suffer? They suffered, first thing, deep venous thrombosis. Second thing, paradoxical thromboembolism from right side of the heart to the left side of the heart through the, what is this place? Patent foramen ovale. This is paradoxical thromboembolism. So they had the DVT, deep venous thrombosis, then that detached, an embolus came, then that embolus came into right atrium. At that very moment, somehow, pressure in the right atrium was high due to coughing, sneezing, straining, or Valsalva maneuver, and due to any reason. If they were having patent foramen ovalis, they will develop a transient shunting of the blood from the right atrium to the left atrium through the patent foramen ovale tunnel, right? And that thrombus might cross from right atrium to the left side of the heart, the paradoxical thromboembolism. And when this travels towards the brain and produces a stroke, because immediately cause of stroke is not clear, so we used to think it is cryptogenic stroke due to some hidden causes, but eventually now we know in most of the cryptogenic stroke we can have underlying patent foramen ovalis. Here there is a very important thing. In patent foramen ovalis, right, it is, how common it is? 25% of the population. So it is considered almost normal variant. In most of the time, it does not create any problem. But if there is DVT plus there is thromboembolism going on the venous side, and then something happen when it is passing through the atrium and pressure in the right atrium increases, and what happens? The potential unsealed area produce a potential connection between the right atrium and the left atrium, and a shift to the left atrium, and through the systemic circulation it goes and produce thromboembolism in the central nervous system and clinically manifesting as stroke, right? We'll call it cryptogenic stroke. And here I want to tell you one thing, that now very recently studies have proven that patient with the cryptogenic stroke, if we medically seal this unsealed area, right? If we stitch it or seal it with some procedure, catheter procedures are done in cath lab, then chances of recurrent cryptogenic stroke are 60% reduced, right? So this is patent foramen ovalis. What is this primary defect? Primary defect is that septum primum did not completely seal well, but problem is with the stitching of the curtain, but curtain size is okay. Curtain is covering the whole window, only it is not properly stitched with the margin of the windows, right? Now, this is not considered atrial septal defect. Now, what is the difference between this and the atrial septal defects? There are many types of atrial septal defects. We will have a full lecture on atrial septal defects. But now, just I want to make something clear, that how patent fossa ovalis is different from atrial septal defects. The most common atrial septal defect, about 70 to 80%, is ostium secundum. Most common is ostium secundum. Now, in ostium secundum, what happened? Look here, this part of foramen, this upper part of foramen ovale has a permanent opening. Permanent opening. Even though its name is ostium secundum, but defect is in septum primum. Again, this was this. It should be completely closed. But if, for example, it does not have full tissue to close, septum primum is underdeveloped. Either it is over reabsorbed or it is underdeveloped and it leaves a permanent hole, right? We call it septum secundum. This is also sort of misnomer, because previously we thought that upper part of rim is made of septum secundum. Now we know it is not made of septum secundum. But here, atrial septal defect in the uppermost part of fossa ovalis, right? If there is opening which is all the time open, we call it atrial septal defect of which type? Ostium secundum type, right? Now you must be thinking, then where is the defect of ostium primum? Actually, here if lower area, if there is defect, this is ostium primum. I'm not going to discuss in detail, but secundum is worth discussing at this moment. And there are many other types of atrial septal defects and their variants which we will discuss later. But I want to say something very special about ostium secundum. Okay, if there is permanent opening here, what is it? Ostium secundum. If permanent opening is here, what is it? Ostium primum. I will not discuss primum because it is atrioventricular boundary problem. Here I will discuss ostium secundum. What is the ostium secundum? Ostium secundum is permanent opening in upper part of fossa ovalis, which is primarily due to deficient tissue. The tissue which was supposed to produce this partition, right? Truly speaking, it was either under development of septum primum, or septum primum initially developed well and then it went under overabsorption due to apoptosis or apoptosis. So ostium secundum develops. Now, ostium secundum is a dangerous situation. It is a dangerous situation. Why? Because, let's come here, the hemodynamic effects of ostium secundum. This is ostium secundum, this is right atrium, this is left atrium. I deliberately made it too much out of proportion so that your cortex remember that upper part is not the true partition between the both atria. And here is your inferior vena cava coming, and here is your superior vena cava coming, right? It's a very simple diagram. And here is your so-called right ventricle, and here is your left ventricle. Now, what happens? If there is permanent opening here, right? Again, I will repeat, it's worth repeating. PFO, patent ductus arteriosus. Patent foramen ovale, yes, patent foramen ovale. The problem is not that dividing tissue is deficient. Problem is that tissue is enough, sealing is not done properly. But so that is not called atrial septal defect. Atrial septal defects are where developmentally the tissue development is less. For example, atrial ASD ostium secundum, what happens that fossa ovalis does not have enough tissue to close the fossa well, right? Due to problem in the septum primum, right? Not scandum. And results what happen that there is permanent opening which is between the right and the left atrium. So what happens? After the birth, as I mentioned, pressure on the left side of the heart is more and right side of the heart is less. So blood will keep on shunting from left side to right side. So what happens? If I am born with atrial septal defect of ostium secundum type, then what will happen? That blood from the left side of the heart will keep on shunting a part of the blood, some of the blood, right, will keep on, of course most of it will be going through, coming from the lungs, some will go to this side, most of it will go to the left ventricle and systemic circulation. But this one which is shunting, what it will do? It will make a trouble on the right side of the heart. Which trouble? Volume overload. Because right atrium is receiving the blood from superior vena cava and inferior vena cava, which is normal, and it is receiving additional volume from the left side. So right atrium will become volume overload, right atrium will become higher pressure, and it will contract and push more blood to right ventricle. So result will be that there will be over volume or volume overload in the right atrium and also eventually to the right ventricle. So right atrium will get enlarged and hypertrophied, and due to this volume overload, right ventricle will also get enlarged. So there is overflow on the right atrium leading to the overflow of the blood in the right ventricle, leading to overflow blood to the pulmonary circulation. And what will happen? If chronically pulmonary circulation system remain under high volume, it will develop pulmonary hypertension and pulmonary resistance will start going up. Meanwhile, at initial stages, just there was shunting from left to right atrium, enlargement of right atrium, hypertrophy of right atrium, enlargement of right ventricle, hypertrophy of the right ventricle, and actually first both things are occurring simultaneously. When there is pressure overload, first hypertrophy occur and eventually dilation of the chamber occur. But when there is volume overload, then hypertrophy and dilation are going almost simultaneously. So these two chambers enlarge and even right ventricular failure can occur. And if right ventricular failure occur, why right ventricle will fail? Very simple, because more blood coming to right atrium, more blood coming to the right ventricle, overflow chronically and persistently into pulmonary circulation. Pulmonary circulation react by vasoconstriction and narrowing of its pathways, vascular pathways, resulting into what? Pulmonary hypertension. And when pulmonary hypertension becomes significant, then right heart fail to pump into lungs. When right heart fail to pump into lung because pulmonary circulation is offering too much resistance, then right heart fails, and then features of right heart failure will come, like jugular venous pressure will go up, or hepatomegaly will be there, ascites will be there, generalized edema will be there. Right? All these problems can be there. So come back. From today onwards, you must know patent foramen ovalis is a common condition. In this, the tissue which was fill up the fossa ovalis is completely developed. Problem is that stitching off or sealing of the septum primum with its margins is not complete. So there is a potential weakness in fossa ovalis, right? And if due to any reason pressure on the left atrium goes up transiently, and if any embolus happens to be in the left atrium, it has a chance to come to the left side of the heart. And if this thrombus is coming from some DVT, we call it paradoxical thromboembolism, and if it goes to the central nervous system, produces stroke, we call it cryptogenic stroke, right? But usually it does not produce long-term hemodynamic problems like ostium secundum type atrial septal defect. Ostium secundum type atrial septal defect is basically how it is different from PFO, that here problem is not the sealing, problem is that tissue which was supposed to close the margins of foramen ovalis, that tissue was deficient. So some part of the floor of the fossa ovalis is missing permanently, and that eventually result into shunting. What is this? Left to right, right atrial and right ventricular enlargement due to over volume load, right? Volume overload, right chambers enlarge, volume overload going towards pulmonary circulation, that leads to what? Pulmonary hypertension, and then that will lead to right ventricular failure. Here is something interesting. Unfortunately, we should not be happy, it's a very sad situation. If pulmonary hypertension becomes too high, pressure on the right side becomes so high, the shunt reverses. Blood starts shunting from right to left. When pulmonary hypertension becomes too high and right chambers find it very difficult, especially right ventricle, to pump to the lungs, then right ventricle will not be receiving the blood, welcoming the blood warmly from the right atrium. Right atrial pressure become more than the left atrium and shunt will reverse. And you know, when the shunt reverses, that initially shunting is from left side of the heart to the right side, and eventually over the long period, due to dysfunction developing in the right chambers, shunt reverses and shunting becomes from right to left. This is called Eisenmenger's syndrome. What is it called? Eisenmenger syndrome. One more thing which I want to make it very clear, that I was telling you about septal access, right? We already know the difference between the patent foramen ovalis versus secundum. Let's talk few more important things and integrate all clinicals related with the transseptal puncture, why it is done and what are the complications. Already we know now what is it? This is the true septum between the, or partition between the right atrium and the left atrium. I think I have become too emotional, I have made it too prominent. And here is your left heart and the left ventricle and right ventricle. And here is inferior vena cava coming and superior vena cava coming. I just want to concentrate here. Transseptal puncture. Why we need it? The reason being that it is one of the safest way, it provides one of the safest way to reach to the left atrium, left side of the heart. For certain procedure, I will tell you the procedures. First, how we reach there. Usually from the femoral vein. In cath lab, the interventional cardiologist, whatever it is. So it is coming through the veins, progressively into bigger veins, then through inferior vena cava to the right chamber, and then they have to find not the medial wall, they have to find the fossa ovalis in the medial wall, right? Because the parent medial wall is too big. Once they locate the fossa ovalis, then they will make puncture. Now, why they should make puncture here? There can be multiple reasons. One reason is, I will just tell you 3 reasons, most common. Number 1, you know what is here? If these are the atrial walls, there are pockets like this here. What are these? Atrial auricles, right, or atrial appendages. Now, sometimes if left ventricle is, due to any disease, left ventricle is too much enlarged, right, and blood is coming from the lungs, for example, the blood is returning from the lungs to opening here and 2 sides coming from here. What are these? Pulmonary veins. Pulmonary veins drain into left atrium. These are openings of the pulmonary veins. And suppose this is what? Yes, septum primum, which is making the floor of the fossa ovalis. Now, number 1, if left ventricle become very large and it is not pumping well, for example, in case of atrial fibrillation, one of the complication is that blood from here, this is the mitral valve, very large, blood returning from the lungs from here directly falls into left ventricle. Or when left ventricle is undergoing contraction, it will close because it is too much dilated, it will accumulate the blood there. But if left ventricle is not effectively pumping, then the blood into this, what is this? Left ventricular appendage or left atrial appendage or left atrial auricle. The blood which is present in this pocket, this becomes stagnant, this blood, because blood is just coming and moving. Normally what happens, that atrium is smaller, and every time when mitral valve is closed, ventricle is contracting and mitral valve is closed, blood is still coming from here, it fills up the appendage, which provides extra expandable chamber, and when this valve open, eventually when atria contract, all this area contract and push the blood down. Normally in these pockets or appendages of atria, blood does not stay stagnant. But if patient has some clinical condition in which blood is stagnant here, then stagnant blood has a high tendency to undergo thrombus formation. So what happens? For example, some patient with mitral stenosis, enlarged left atrium, and there is some stagnant blood here. They repeatedly form thrombi here. What is the biggest problem? These thrombi will break down from here, blood clots will break down from here, they will come to the left ventricle and float to the systemic circulation, and one of the destination can be central nervous system, and such patient can suffer strokes. They have very high risk of stroke, or they get, even if they survive some stroke, they keep on getting repeated strokes. For such patient, we come with the catheter from here, right? In fossa, what is this? Ovalis. We make a transseptal puncture, and the choice of the place is that in this septum, we choose puncture point not in the middle. We choose the puncture point. For example, this is okay. This is the what was this our? We choose the puncture point in lower and posterior area here. You know why? Because catheter and needle that can be directed upward into this pocket. And then we can occlude this, there are different procedures. We occlude this pocket, right? So that blood does not go there and does not make a thrombus and does not make an embolus and does not eventually result in stroke. So one purpose to make this puncture is transseptal puncture. One purpose is that if you want to occlude the left atrial appendage. Another purpose can be if some patients who have atrial fibrillation, this source of tachyarrhythmia is the myocardium around the orifices of, what is it? Pulmonary veins. When pulmonary veins are opening into left atrium, some myocardium is, you can say, they creep into the vascular system of the pulmonary veins. So where pulmonary veins are attached with the left, what is this? For example, if this is pulmonary vein opening into left atrium, some of the myocardium goes over here. But this myocardium is very naughty, rather nasty myocardium. Because this myocardial tissue in many people turn arrhythmogenic. It produces abnormal rhythms. And many a time it becomes a source of atrial fibrillation. We'll discuss again full lecture on atrial fibrillation later. So if these become the source of atrial fibrillation, one way to manage it, and these days this is the most popular way to manage, is that we come transseptal, right? From right, puncture the floor of fossa ovalis, come to the left atrium, and then we do tissue ablation around these orifices, so that abnormal electrical activity is, the myocardium with abnormal electrical activity is disconnected with the rest of the atrium. But blood keep on coming. We call it isolation of pulmonary veins, IPO, isolation of pulmonary veins. It is one of the way to treat the atrial fibrillation, which is taking origin from nearby myocardium, which is nearby the pulmonary veins orifices. So that when we take, what is this, catheter there, if these openings are here, we isolate the arrhythmia producing myocardium from the rest of the atrial myocardium by ablative process or by thermoablation. We can do cryoablation, we can do thermoablation, and now we are doing radio frequency ablations and ablations. We will again study these ablation processes later. There will be so many lectures on cardiology. But right now my only purpose is to tell that why what is the clinical importance of what is the clinical importance of medial wall. One is that you must be able to recognize and understand from where the foramen, or more truly fossa ovalis, came, and why we puncture through that and reach to the left side, and why we want to go to the left atrium. Either we want to occlude the left atrial appendage, or in patient with atrial fibrillation whose fibrillation origin is around the orifices of pulmonary veins, to isolate those sources. Or sometimes we make a puncture from upper anterior part to move downward. You know why? We push the needle and then catheter towards the mitral area for doing different mitral procedures. For example, we do balloon valvoplasty, or there are many procedures we will not discuss now. That we will discuss with the mitral valve diseases. So what I wanted to tell you, that there are multiple reasons that we have to do transseptal, what is it? Puncture, right? But I have told you only 3 reasons. You need to go up from, you should stay within the foramen, within the fossa ovalis. Now puncture can be from lower part and from posterior part. Vector is upward to seal the, to occlude the auricle of left atrium, or puncture is interiorly and inferiorly, and that is very commonly done, superiorly and interiorly, superiorly, to go down to the mitral area, right? So it is important that if you have to do transseptal puncture, it is important that you should know that you should puncture through fossa ovalis. But it is also more important to know what is the vector or trajectory of your needle and catheter or sheath, right? Then complications. I told you complications. One complication is that if rather than fossa, you puncture too much superiorly or posteriorly, you may puncture into extracardiac tissue, and you might produce, cardiac tamponade, in which too much blood accumulates into pericardial cavity so rapidly that pericardial cavity cannot stretch so fastly, so it compresses the cardiac chambers. So in these patients, look here, that, okay, suppose this is normal heart, I should make it like this, and this is pericardial, suppose, sac around it, right? Now, if puncture occur, blood will come into, if you have made puncture here, blood will come into this area. And when blood will come into this area, what will happen? Pressure will increase and it will compress the cardiac chambers. So cardiac chambers will be pressed, and what is this? Blood present in pericardial sac. Remember, if there is any excessive fluid in pericardial sac, just presence of excessive fluid is called pericardial effusion. But if this fluid keep on strangulating the heart and producing dysfunction in cardiovascular system or obstructive shock, then we say there is tamponade, for example. And if this tamponade is due to accumulation of blood, then we call it hemotamponade. So in this case, there is a hemotamponade or a cardiac hemotamponade, and this hemotamponade, when it will compress the cardiac chambers, number one, there will be forward failure. If heart is unable to receive the blood, can it pump out? It cannot maintain the cardiac output. So patient's pulse will keep on getting weak. Patient's pulse volume will keep on going down. Cardiac output is dropping. Patient's blood pressure will keep on dropping. And do you think blood can come back and enter into heart, which is being strangulated by the accumulated blood in pericardial sac? No. So blood will keep on accumulating in systemic veins, and which is clinically visible in the jugular venous system. So jugular venous pressure will go up. So what will happen in this patient? pulse will keep on getting weak and blood pressure will keep on falling. It's one and the same thing. So falling blood pressure and rising jugular venous pressure, and if you auscultate the heart sounds are either not audible or as if they are coming from Mars, as if they are very distant and muffled heart sounds. And this is called, this type of situation is a very serious emergency situation and cardiac tamponade, that there is rising jugular venous pressure, falling pulse, volume and blood pressure, and absent, distant or muffled heart sounds. This is called Beck's triad. Beck's triad. So, even though it's considered very safe procedure, transseptal puncture, but if you don't have a proper concept of the medial wall, then you can end up with, if you are making superior or posterior, you can end up with extra cardiac tissue rather than the other chamber, and that may result into cardiac tamponade. Then I told you previously that if your needle is directed too much anteriorly, it can puncture the root of aorta, and that can be catastrophic as well. And sometimes this floor is so loose that you push the needle, there's little tenting, right? That little tenting is required. That confirms that you are pushing the floor. But sometimes it tends too much, and if you are too aggressive, you have taken 10 cups of coffee, you push the needle too much, the needle go through this to the left chamber and then go out. That will be also tragic, right? So what I'm saying, that transseptal access is good, but there are danger zones as well, right? Now, I think this is enough for today. Tomorrow we will continue, next time we will continue with the medial wall, but inferior most part of the medial wall, where there is electrical window between the atria and ventricle, AV nodal region, and triangle of Koch. This Koch is not C-O-C-K. This is not the husband of the hen. This was a doctor, Dr. Koch. He found a special anatomical mapping as a triangular area in the lower medial and inferior part of the right atrium, from where we could find the AV nodal area, and we do very special type of ablation procedures there to prevent the re-entrant AV nodal tachycardia. So in coming lecture, I will explain what is the triangle of Koch, what are its boundaries, where is the AV node and bundle of his, or AV nodal region or electrical grid, and how AV nodal re-entrant tachycardia are produced, what are those tachycardia's mechanism, and how slow pathway, that tachycardia re-entry has one slow pathway and one fast pathway, how slow pathway ablation is done, and why we should not do fast pathway ablation. See you in the next lecture. Thank you very much.